Welcome to our virtual monthly meeting on all things celiac. Today's webinar is Aging Well with Celiac Disease, hosted by the National Celiac Association and the Celiac Research Program at Harvard Medical School. I'm Lee Graham, Executive Director of the National Celiac Association. Serving the gluten-free community since 1993, NCA provides educational resources on our website like Ask the Dietitian, Raising Our Celiac Kids, and Supporting Celiac Seniors. Zoom support meetings are open to all on the second Tuesday of every month. And my thanks to all of those who have generously donated to our food insecurity initiative called Feeding Gluten-Free. Together, we have given over $1 million worth of gluten-free food to food pantries in 49 states. For today, you are welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. Closed caption is available by clicking on the CC button. If you're still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org or 857-282-6470. Also, this session is being recorded and will be available for viewing on NCA's website, nationalceliac.org. I'm honored to introduce our moderator for today, Dr. Ciarán Kelly. Dr. Kelly is a professor of medicine at Harvard Medical School and the J. Thomas Lamont Professor of Gastroenterology at Beth Israel Deaconess Medical Center in Boston, Massachusetts. Dr. Kelly earned his medical degree from Trinity College in Dublin, Ireland, where he was a foundation scholar and recipient of numerous academic awards. Dr. Kelly has been engaged in patient care and research in celiac disease for more than 30 years. An internationally recognized expert in the diagnosis and management of celiac disease, Dr. Kelly specializes in difficult-to-treat enteropathies. In 2004, he was a founder of the Celiac Center at Beth Israel Deaconess Medical Center and continues to serve as its medical director. In 2013, he co-founded the Celiac Research Program at Harvard Medical School, which brings together celiac disease researchers and educators from Harvard teaching hospitals, including Boston Children's Hospital, Massachusetts General Hospital, and Beth Israel Deaconess Medical Center. He is a founding member and a past president of the Society for the Study of Celiac Disease. Dr. Kelly is the author of more than 300 clinical and basic research, book chapters, invited reviews, and original research articles appearing in medical and scientific journals, including Gastroenterology, Vaccine Infection and Immunology, the Journal of Clinical Investigation, the Lancet, and the New England Journal of Medicine. Welcome, Dr. Kelly.
Thank you, Lee, for that very kind invitation. It's great to have you and the NCA together with us hosting this webinar on Aging Well with Celiac Disease. As Lee mentioned, there is a Q&A feature at the bottom of your screen which you can use, and I know many of you have already submitted questions, which we will address as many of those as possible at the end of the lectures. The session is being recorded and it will be available later on the NCA website. That's www.nationalceliac.org, and also available on the Harvard Medical School Celiac Research Program website. Ongoing education credits are available for this session for dietitians, nurses, physicians, and social workers who have pre-registered for the webinar. Now it gives me great pleasure to introduce my friend and colleague, Dr. Joe Murray. Joe is a professor of medicine and a consultant with a joint appointment in immunology and gastroenterology hepatology at the Mayo Clinic in Rochester, Minnesota. Dr. Murray's training in gastroenterology and population health, as well as his broad experience in clinical, translational, population, and basic research, provides him with a wide-ranging perspective of the discipline of gastroenterology, and most specifically, celiac disease. He has been engaged in patient care and research in celiac disease for more than 30 years. There's an echo there from my experience, similar duration. Dr. Murray has published over 400 original articles, primarily on celiac disease, malabsorption, esophageal disease, and esophageal physiology. And he has served as senior author on the development of guidelines related to celiac disease. Dr. Murray has been an active participant in the American Gastroenterological Association Institute's Clinical Practice Updates Committee, and is co-author of 2 of those clinical updates, both of which were published in Gastroenterology. And so it gives me great pleasure to introduce Joe, who's going to launch our webinar this afternoon.
Super, Ciarán, many thanks indeed. I'm delighted that the National Celiac Association and Harvard's Celiac Center would invite me to participate. I'm sorry I can't be there in person. I'm right now in the next parish to the east, which is Connemara in the west of Ireland. So I'm going to go ahead and share my screen and we'll get started. So I'm going to talk about celiac disease. Initially, when I approached this, I thought about celiac disease in the elderly. But then my physician daughter, who's a gerontologist, reminded me that elderly has specific connotations, and I am now potentially in that category, at least by age. So I've renamed it celiac disease in the older person. These are my disclosures, which I'm delighted to share because there's now a lot of commercial interest in celiac disease, which I'm hoping will be fruitful in the future to provide options. But what is elderly? In California and Florida, it's over 65. The legal definition for older person, and there is actually an Older American Act that defines us. I belong in that cohort of persons over 60. Elderly person, however, means a person of 60 years or older who is incapable of adequately providing for his own health and personal care. We also have to think of what's called the frail elderly. But then most depressing of all is the concept of the aged immune system, which, according to my colleagues in immunology, happens about the age of 40. This is taken from Jorge Goranze and Connie Wayland, who are now at Mayo, from their discussion of immunosenescence, this concept of aging of the immune system. And these 3 boxes here illustrate the kind of immune T-cell repertoire of the different phases of adult life. The young adults, 20 to 30 years of age, have got quite a lot of different naive cells ready to learn, basically. And they do have some degree of memory cells. Let's think of red ones as not necessarily good ones, but ones that may be auto-directed, that is directed against self. In our category of 60 to 75, we've lost a lot of our naive repertoire. So we're perhaps less ready to learn new things. And for example, we're less ready to mount vaccine responses. Our vaccine responses are less robust to brand new things, including, unfortunately, to the current pandemic's virus. As you get older, we tend to do a less effective job of mounting the response both to vaccine and to virus. And on the other side, we also have more clones of T cells that are autoreactive. Finally, once we get into more advanced age, over 75, we have basically lost most of our naive pool. And instead, most of our T cell repertoire is made up of families of T cells that have very specific tasks. So we're very good at fighting specific things that we recognize, but not so good about learning new things. And occasionally we have clones of T cells that are strongly autoreactive. So we tend to see more increased autoinflammation. We've also lost some of our T memory cells. And for example, one of the things that we find is shingles, of course, tends to be the bane of the older patient. It becomes more common, and it's now recommended that we get vaccines to stimulate our immune response against these viruses so that we don't forget about them. And then what happens, for example, shingles, and shingles can even happen earlier in patients with celiac disease. But this just gives a sense of immunosenescence is a significant issue with regard to aging. We're going to talk about epidemiology of celiac disease a little bit. We can talk about, can it start in elderly or older patients? We'll talk a little bit or address diagnosis and diagnostic delay, initial evaluation, follow-up, healing, antibodies, complications, possibly the issue of can we reverse fracture risk? Because as many of you are aware, there is an increased association between osteoporosis and celiac disease. So I'm going to pause, and Chris has a polling question, and we'll bring up the polling question at this time. So the polling question is as follows. Elderly patients who are newly diagnosed with celiac disease will heal their intestine, and you have one choice, faster than young people, slower than young people, will never heal their intestine no matter how long they're on a gluten-free diet. And we don't expect healing because patients will not adhere to a gluten-free diet. So all of you attending, you have the opportunity to vote. And of course, these are 4 choices. That doesn't mean that they're the only correct answers. There may be other things that, of course, that we're going to learn about during this session today about older patients and celiac disease. So, Chris, when you think there's been sufficient response, we'll bring up the answers. And so quite rightly, you've identified, and I'm delighted to see how much participation there are. Zoom, I think, is wonderful. You get a lot more participation than in person. That feel that healing is slower than young people. And then we'll continue. So epidemiology, celiac disease occurs at all age groups. This, however, is specific data on older patients from Olmsted County, the county where I usually work in Minnesota. And we've counted all of the people who were diagnosed with celiac disease back to about 1950. And while we've documented a substantial increase in celiac disease across all ages, it is particularly marked in the older individuals, a little bit more female than male. And that difference that seems to occur of more women are diagnosed than men seems to be maintained throughout life into this older cohort. So like our younger cohort, we saw a dramatic increase in celiac disease diagnosis starting in the mid-1990s. So when some of the issues that we consider, we're going to consider the issue of aging as a decline of physiologic processes, however much we might want to deny that or resist that. Secondly, the issue of it was historically considered a pediatric disease, but really it can occur at any age, including advanced age, for an initial diagnosis. However, there's little that has been specifically separated out about celiac disease in elderly populations. It is clear, however, that there are non-specific presentations seem to be more common in this age group. And there is overlap with aging symptoms such as fatigue, weight loss, decreased appetite that tend to be an issue, especially for the frail elderly. And separating out the non-specific presentations that could be related to advanced age from what could be underlying celiac disease could often be a challenge. This is data taken from NHANES. The NHANES is the National Health and Nutrition Surveys that have been done of the US population now for over 30 years. And we had the opportunity to test every body sample who was over the age of 50 in these groupings and looking at the total population. And you can see that each of these by decades from 88 to 94, 99 to 2004, and 2009 to 2012, there's been a substantial increase in the prevalence of celiac disease, and most of these are undiagnosed. And it's predominantly non-Hispanic whites, but also Hispanic individuals have often also seen a substantial increase in celiac disease in individuals who are considered Hispanic and over the age of 50. So celiac disease is becoming more prevalent in this age category. Another study that we carried out, and this is looking specifically at the older individuals over the age of 50, looked at the new onset of celiac disease in patients who had previously been tested negative. And this is based on a population-based study where we were able to test a large proportion of the population with serum samples and then follow up to what happened to them and then retest a substantial proportion of them later on. And we were able to identify that celiac disease could occur in individuals. The rate is quite low, but if you extended the period over 20 years, you could see a significant percentage of individuals who developed celiac disease de novo at over the age of 50. So it wasn't just a hidden disease that was becoming apparent, it was actually present. Another study where we looked again in our population-based study of what we called undiagnosed celiac disease in individuals over 50, we were looking for, well, what clues were there from their medical records? And one thing about Olmsted County, we have medical records that stretch back to the beginning of the 20th century. So we're able to reach back into people who've lived here to their entire medical record and looking at individuals who were seropositive for markers for celiac disease compared to seronegative in our community. We could not see any difference between things like diarrhea, weight loss, abdominal pain, irritable bowel syndrome, or even deficient hemoglobin. So there was a slight tendency or trend towards a deficient hemoglobin diagnosis in those who had undiagnosed celiac disease. Dermatitis herpetiformis is in there as a specific diagnosis. And of course, that only occurred in those who were seropositive. And what it illustrates is those patients who had likely been diagnosed with dermatitis herpetiformis many years ago were not adhering to a gluten-free diet because they had underlying celiac disease and probably were being treated by suppressive medications alone. When we looked at individuals who were subsequently diagnosed with celiac disease, again, these are older individuals whose stored serum sample had been seropositive for celiac disease. When we looked at what did they develop at the time of diagnosis, iron deficiency, dermatitis herpetiformis, the very itchy skin rash of celiac disease. Diarrhea did occur in about 15% of those who were ultimately diagnosed. Some were screened because they had a child diagnosed with celiac disease. And unfortunately, there was one individual who was diagnosed with lymphoma. Another way of looking at this older population of undiagnosed individuals versus individuals who are seronegative for celiac disease, we looked to see were there any other clues. And the only two things that were significant was a presence or a diagnosis of osteoporosis, and secondly, a diagnosis of hypothyroidism. And hypothyroidism, of course, is probably the most common autoimmune condition affecting older individuals. All the other things we had searched for, peptic ulcer disease, even anemia, which had a trend but still was not significant, conditions such as neuropathy, depression, seizure disorder, cancers, including celiac disease-associated cancers, were not significantly so. The only thing that was a clue to this hidden disease was osteoporosis and hypothyroidism in these individuals over the age of 50. What about laboratory findings? Now, we have a lot of doctors in Rochester, so there's a lot of easy access to medical care, a lot of routine medical care. So we were able to look at things like body weight, for example. There really wasn't much any difference in body weight between those who were seronegative in the left-hand column and seropositive in the right-hand column. Height was no different. Body mass index was perhaps slightly different, with the patients with undiagnosed celiac disease slightly lighter than the patients without. Cholesterol was a little lower in the patients who were seropositive for celiac disease. Ferritin level was significantly lower. Everything else, iron level, hemoglobin, there really wasn't much difference between those. Folate, even albumin, none of these changed. So there was very little obvious difference from a laboratory perspective, except for the slightly lower cholesterol and lower iron stores than in those who were seronegative. What about mortality? What about follow-up of individuals who are seropositive for celiac disease? And this is taken from our study where we tested the serum samples from an older NHANES cohort from 1988. And these are all the individuals who participated in that survey over the age of 50. And there did seem to be an increase in mortality in those who were seropositive. And this was something we also confirmed in a separate study with a longer follow-up, but that was in young individuals followed into old age. But in this case, older individuals over the age of 50 who were seropositive were more likely to die than those who were not. Now, this could well be related to some other confounder. And in this case, we found there seemed to be the excess mortality was often associated with respiratory or lung deaths, which was interesting, but not fully explained. What about the issue of diagnostic delays? We know that this applies to many individuals with celiac disease, but especially in older individuals, where delays can be as long as 17 years in some surveys. Certainly anecdotally, I have seen patients whose symptoms of celiac disease dated back many decades. Why does this happen in older individuals? Well, there's age-related symptoms, or what I call diagnostic distractions. Concern for blood loss in a patient who is anemic or iron deficient. It's almost a knee-jerk response to check for colon cancer and ulcer disease. And of course, those are critically important conditions and are especially common in older individuals. But they often become the major focus for diagnostic efforts to the exclusion of looking beyond. Long-standing symptoms often result in what I call a lack of complaints or lack of inquiry. Patients either have accepted what they've experienced as a symptom as part of life or maybe part of aging, or perhaps it's not asked about. And another part, I think, another question I think is particularly important is not asking about celiac disease in family members. And I certainly make a point when I diagnose celiac disease in a younger adult, I will ask about their parents and recommend that it be discussed with them about whether they should be tested for celiac disease or not. I would be fairly pro-testing for celiac disease, though we don't yet have sufficient data to recommend that everyone who has no symptoms be tested for celiac disease if they have a family member. But I think many of us in the field would say that there's often hidden symptoms and many things that certainly for older individuals that have been ascribed to age may actually be due to the hidden celiac disease. The clues, as we've mentioned, hypothyroidism or thyroid disease, weight loss, deficiencies of iron and zinc, anemia, and unfortunately, malignancy sometimes is the first presentation of celiac disease. I'm going to move on a little bit to management of celiac disease in elderly, and you're going to hear a lot more expert management information in the next talk. How do we approach the newly diagnosed, those who are long-standing with celiac disease, many of whom have been treated, hopefully, but some have been untreated for a long time. Perhaps they went back on gluten after an initial response to a gluten-free diet. There may be uncertainty about their diagnosis, and it often means we have to review a prior diagnosis and what data had been obtained. And sometimes that's quite challenging if it was 20 or 30 years ago. And I will often retest their HLA susceptibility if I feel that the original diagnosis was not based on robust information. And there's been at least one study suggesting that there can be surprisingly high frequency of the lack of HLA or genetic susceptibility for celiac disease who were diagnosed historically more than 25 years ago. But again, each case should be taken on its merits. So what are the approaches I see as the management that are critical for our older patients. A lifelong gluten-free diet, of course, may be challenging, and some people will say it's harder to adapt to new dietary habits. We will hear more about that. I would like to think that I can learn new things over the age of 60. And every gastroenterologist should be aware that prevalence is increasing in the older patients. Elderly are a high-risk population in many circumstances. There is late or underdiagnosed disease, and early and correct diagnosis can prevent many of the celiac-associated complications. And gluten restriction is feasible and beneficial, but we will hear more about that later. So what about a new diagnosis, especially in somebody who might be in advanced years over the age of 65? Well, one question I'm often asked is, how long has this been going on? And I don't know. I will seek, how long have you had any symptoms or signs of the disease? Had you had periods of GI distress earlier in life? Were there early life symptoms? Is your bone density much lower than peers? And for those physicians who read bone density, you know that standard reading is now T-scores, which compares us to young adults of the same sex, which is most unfair. But when you want to compare them to peers, you look at the Z-score. How much does the bone density, is it unusually low for their age? And if it is, that implies that they've probably have had celiac disease for quite some time. Do they have a history of being refused as a blood donor? And how far does that go back? Do they have multiple deficiencies, which might indicate long-standing disease? And then one also has to consider, as a new diagnosis, that there are more, let's say, alternative diagnoses, and especially in patients whose blood antibody test was negative. Especially important are drug-induced injuries, or some of these rare conditions like lymphoproliferative disease or immunodeficiency diseases. They tend, especially acquired disorders, tend to be a little more common as patients get older. So especially important is to investigate these are patients whose antibodies for celiac disease were negative at initial testing, or if they weren't tested. So the initial evaluation, I will look for micronutrient deficiencies. I find them especially common in older individuals: iron, B12, folic acid, vitamin D, zinc, copper, and vitamin B6. Copper is especially, it's not particularly common, but it is associated with severe neurologic or hematologic problems, often slow to reverse even with repletion. Vitamin B6 is particularly pernicious as a deficiency because it can be associated both with neuropathy and fatigue. Bone density, if it's not already done, calcium and albumin will be measures that I'll take. If albumin is low, I will consider that patient at high risk for malignancy or progressive disease. Liver blood tests. I will also routinely undertake body imaging. So that typically would be CT enterography or body or CT abdomen and pelvis, because of the risk of prevalent neoplasms is higher in the patients first diagnosed over 50. And their risk for getting those malignancies is greatest in the first year after diagnosis. Also, I don't avoid endoscopy in these patients because the risk, again, the risk of having associated disorders is greater in the older patients. So I will want at least once to look at the proximal small intestine. What about histology in the older person? We know that many solid organs have age-related changes. However, the intestine is an exception. Intestinal architecture isn't the same in the older, even the advanced age, as it is in young. So there isn't a flattening of the intestine that occurs by nature in older individuals. There are other causes by which the intestine can be flattened in the elderly, but intestinal architecture in the normal or generally healthy elderly should be pretty intact. In fact, even in the sick elderly, it's pretty intact. Celiac histology is similar in older and younger individuals. However, conditions such as collagenous sprue, ulcerations, strictures, and neoplasms are more common in the older individual and often require more intense evaluation in a celiac center. If a patient is otherwise healthy, and we've made the diagnosis and they're otherwise healthy, I will routinely undertake a follow-up endoscopy 2 years later, so long as their health is generally good. And for example, a rule of thumb I take, if they're still involved in their colon cancer screening program with regular colonoscopy, I would see no reason not to do a follow-up endoscopy at least once to show that healing is occurring. Recognizing, however, that healing will be a little slower in older patients.
3 minutes, Dr. Murray. Thank you.
Thank you. And complications, autoimmune disorders become more common with advanced years of exposure to gluten. It's still a little controversial, but certainly there is some data. Lymphoma rises with the age at diagnosis of celiac disease. And of course, malignancy may be the first presentation of celiac disease and sometimes precedes the diagnosis of celiac disease. Bone density in older individuals, it often can be lower. And so this is looking at seropositive individuals who have hidden celiac disease. Their bone density tends to be a little lower. So I want to come to the issue of bones. Bones are very important in the elderly. One of the most common reasons for advanced morbidity is somebody falls and has a fractured hip. Osteoporosis is more common in all elderly, and it is defined by comparison with young adults. It is worse in those with celiac disease than those without. Unfortunately, fracture risk seems to persist despite the gluten-free diet. However, the good news is many of those fractures are peripheral fractures. That's hands, wrists, ankles, not hips or spine. Those are important, but they seem a little less common. It's also important that gluten-free diet is essential for the drugs that are used to treat osteoporosis are essential to work, and calcium and vitamin D absorption is critical for many of those drugs. There's no point in taking a drug you almost have to take out a mortgage to pay for if you don't have adequate calcium and vitamin D availability, if your celiac disease has not healed. And oral bisphosphonates similarly often are poorly absorbed in patients whose celiac disease is not healed. And of course, we also have to be aware of hidden osteomalacia. And the clue in the older patient is somebody has weakness getting out of a chair or getting out of bed. And that's because along with the bone softening is also weakness of those muscles. So osteomalacia, softening of the bones, it's due to deficiencies. You get elevated parathyroid hormone, you have pseudofractures, proximal muscle weakness. And if you treat those patients with an anti-resorptive agent, you can often end up with a low calcium and tetany or muscle spasms. Treated with a gluten-free diet and very high doses of vitamin D weekly, which requires close monitoring. Infections and vaccinations are important for all older individuals, but especially in patients with celiac disease. And hyposplenism seems to be more common in those in older patients with celiac disease. Of course, I will always focus on vaccination and remind people of vaccinations. And I do start pneumococcal and shingles vaccine earlier than others. So in summary, consider celiac disease testing in the older patients. You're never too old to benefit from treatment. Beware of deficiencies, seek complications, and follow up patients. Thank you for your attention.
Joe, thank you for a tour de force of celiac disease in the older person. That was wonderful. Next, it's my pleasure to introduce Katarina Mollo. Katarina is a registered dietitian and director of education at the National Celiac Association, the NCA. She is also newly appointed as a clinical dietitian at the Center for Celiac Research and Treatment at Massachusetts General Hospital. Katarina's passion for celiac advocacy led her to pursue a career as a registered dietitian specializing in celiac disease. She has a Bachelor of Science in Food and Nutrition, as well as a Master of Education in Nutrition Education from Framingham State University. Katarina was diagnosed with celiac disease as a young child and also has a daughter with celiac disease, so she knows firsthand what it is like navigating everyday life on a gluten-free diet. So Katarina, it's a pleasure to introduce you and have you speak to us. Second talk.
Thank you so much for that wonderful introduction, Dr. Kelly, and the invitation to present. So I'm just gonna share my screen with you. Right. Hi, everyone. I'm so excited to be here this afternoon to talk to you about celiac disease in your senior years. So I have quite a lot of slides to cover. So I'm just going to jump right in. And first, we're going to do a little poll. If I can get that poll up. Right, so the question is, what is the most common symptom or complication seen in older patients with celiac disease upon diagnosis? Is it diarrhea, weight loss, reflux, anemia, or dementia? So pick, an answer you think is correct, and I will circle back to this question a little later in the presentation. And I have nothing to disclose. And first, I just want to do like a quick overview of what I'll be covering today. So I'll start out talking about common nutrition challenges for seniors, then talk about nutrient deficiencies related to celiac disease, the treatment and the diet. And then I'll cover gluten-free meals at hospitals and assisted living facilities. And finally, I will share some resources that are available to you. So, those of you that are older with celiac disease, you're definitely not alone. I talk to seniors all the time, even 90-year-olds, that were just diagnosed, and also people who've had celiac disease for a long time. And we know that about 1% of the population has celiac disease, and there are about 54 million people in the US that are over 65. So that's actually, potentially over 500,000 seniors with celiac disease in the United States. And it's also estimated that about 19 to 34% of new cases of celiac disease are aged 60 and over. So you're definitely not alone. And as we age, we often develop nutrition-related challenges that are associated with aging. So it's common that seniors with celiac disease also struggle with other conditions, in addition to celiac disease. And here are some common ones to be aware of, such as anemia, osteopenia and osteoporosis, decreased taste and smell, problems chewing and swallowing, protein energy malnutrition, sarcopenia, loss of muscle mass, obesity, diabetes, cardiovascular disease, hypertension, dementia, and wounds and ulcers. So I also want to touch upon some other challenges for seniors that can affect nutrition and also quality of life, such as limited financial resources, limited social resources, increased dependence on others for food, and some struggle with limited mobility and also poor vision. And the reason I bring out poor vision, because it can affect label reading. And that's really important to address because, that can be a huge barrier to getting better. And here are some key nutrients to focus on as we age. And this refers to the aging population in general, not just those with celiac disease. So nutrients that all older adults may need more of are fiber, calcium, vitamin D, B12, potassium, protein, and fluid. Okay, so before I go on to the next slide, let's take a look at the poll that you just did. Oh, wow. Okay, so you guys are really smart. You picked anemia, and that's actually the correct answer. And a lot of you picked also diarrhea. That's a good one. A lot of, people associate diarrhea with celiac disease, but actually diarrhea is not a common symptom in seniors. And weight loss, that's a good one too. A lot of people have the weight loss as well. So as I said, the anemia is the most common presentation at diagnosis. Actually, up to 80% of seniors have anemia. And this is most likely due to, iron deficiency, but can also be due to B12, B6, and folate deficiencies. And other deficiencies we see are zinc, copper, and vitamin D. And also sometimes, all the other fat-soluble vitamins. as well as calcium malabsorption. And up to 70% have osteopenia. So bone density scan or DEXA scan is recommended after diagnosis. So now what's the treatment? So it's really important to see a gastroenterologist that's familiar with celiac disease, and also crucial to consult with a registered dietitian skilled in celiac disease to get you started correctly on the gluten-free diet. And they can also help you with any problems and adherence to the diet. And currently, the gluten-free diet is the only treatment for celiac disease. And those with anemia, like I just mentioned, they may need iron, B12, and or folic acid supplementation under supervision. And those with reduced bone density may need calcium and vitamin D. And a multivitamin may also be recommended. And it should be age appropriate and labeled gluten-free. And it's really important to have regular follow-ups with your GI doctor to monitor your celiac disease. They will check for celiac-related antibodies and also monitor nutrient deficiencies or checking, for other conditions or complications. And your doctor will decide how often you need to see them. Usually it's at least annually. So as we mentioned, iron deficiency anemia is very common. So here are some iron-rich foods that you can include in your diet, such as meat and poultry, fish and seafood, eggs, legumes, nuts and seeds, dark leafy greens, including spinach and chard. And to optimize absorption of iron from vegetable sources, take them with foods high in vitamin C, such as orange juice. I also mentioned that osteopenia is common in seniors with celiac disease. So osteopenia is reduced bone density, and it can lead to weakened bones. It's not as severe as osteoporosis, but it may progress to osteoporosis. And people with celiac disease are at risk of developing osteopenia due to malabsorption of mainly calcium and vitamin D. So it's very important to stick to a strict gluten-free diet to avoid malabsorption. And you should get at least 1,000 to 1,200 milligrams a day of calcium, from supplements and eating calcium-rich foods, and 1,000 to 2,000 IUs a day of vitamin D from supplements, food, and the sun. Also, resistance training and weight-bearing exercises are beneficial to build bone density. And also avoid smoking, limit alcohol and caffeine. And medications are sometimes used, such as bisphosphonates, to prevent or slow progression to osteoporosis. And osteopenia should be monitored by your doctor. And here are some calcium-rich foods that you could include in your diet, such as dairy, milk, yogurt, cheese, lactose-free milk, dairy-free milk, such as soy, almond, cashew, coconut milk, and check the label for gluten-free status. Another option is calcium-fortified orange juice. And also tofu and soybeans are also high in calcium. And again, check the label for gluten-free status. And some veggies are high in calcium, such as broccoli, collard greens, kale, and spinach. So here are some good sources of vitamin D that you could include, such as, sunlight. A lot of people don't think about that. So aim to get about 10 minutes of midday sunlight several times a week. Eat fatty fish, such as salmon. And fortified dairy products and milk alternatives that I just mentioned on the other slide also contain vitamin D. So if you include those, you'll get both calcium and vitamin D. So I just want to note that there are some common nutrition challenges with the gluten-free diet. It can be low in fiber, which may cause constipation. It's generally, higher in fat, sugar, and high fructose corn syrup. And this is often added to increase the palatability of gluten-free products. And the gluten-free diet is often, low in certain vitamins and minerals, such as B vitamins, iron, calcium, magnesium, and zinc. And finally, gluten-free products are rarely fortified or enriched with iron, folic acid, or other B vitamins, like some other gluten-containing counterparts, like regular flour and regular cereals. They're usually fortified with these vitamins and minerals. So what can you do? Well, focus on nutrition. Eat a variety of gluten-free whole foods, fruits, veggies, whole grains, nuts, seeds, legumes, lean meats, poultry, fish, seafood, low-fat dairy, and healthy fats such as olive oil. And choose the more nutritious gluten-free whole grains first, and I'll mention those on the next slide. And drink plenty of water and other fluids throughout the day to avoid constipation. And when choosing processed foods, choose enriched or fortified labeled gluten-free grain foods such as breads, cereals, rice, and pasta. And here are those nutritious grains and seeds. So try and include these in your diet, such as amaranth, buckwheat, chia seed, flax, quinoa, sorghum, and teff. And they are high in nutrients and fiber, and always choose those that are labeled gluten-free due to high risk of cross-contact with gluten. And here are some other high fiber foods. And I like to include this because, when we think of high fiber, most people just think of grains. But as you can see, there are many foods that are very high in fiber that are not grains. A lot of fruits and vegetables and legumes are very high in fiber. You can see here, raspberries has 8 grams of fiber per cup. Avocado has 10 grams of fiber. Boiled split peas has 16 grams of fiber. And you compare that to the quinoa here, which is 5 grams of fiber. And then cooked green peas, 9 grams of fiber, and almonds, 3.5 grams of fiber per ounce. And women should get around 25 grams per day of fiber, and men around 38 grams per day. And always try and increase fiber gradually to avoid GI symptoms, and make sure to drink plenty of fluids throughout the day, unless you have a fluid restriction from your doctor. Try and drink water with every meal and snack, and keep a water bottle with you to drink throughout the day. All right, so I know we all look at the ingredient listing on the food label because, we need to read ingredients to look for gluten. I also want you to pay attention to the nutrition facts label. So here are some things that you want to get more of, such as dietary fiber, vitamin D, calcium, iron, and potassium. And a good rule of thumb here is to choose foods that have at least 20% of the daily value of these nutrients. So the daily value is over here in the right-hand column. And here are some nutrients to limit. And those are saturated fats, sodium, and added sugars. And a good rule of thumb for these foods is to choose those that have less than 5% of the daily value. So I want to switch gears now and talk about gluten-free accommodations, such as meals at hospitals and long-term care. So celiac disease is considered a disability under the Americans with Disabilities Act, or ADA. And although celiac disease is not directly stated, the ADA recognizes a disability when it affects major life activities, such as eating and digestion. And what does this mean? So it means you have the right to accommodations for a gluten-free diet in certain circumstances, like, for instance, when you're at the hospitals. So hospitals are required to provide you with gluten-free meals during their stay. And for a planned hospital stay, we recommend, communicate with the hospital ahead of time, contact their nutrition department and ask them about availability of gluten-free foods and their procedures. Ask, is there a gluten-free menu available? What are the options? Another good idea might be to also bring your own foods if there are specific things that you want to have with you, like, your favorite cereal or bread. So to avoid issues, immediately inform healthcare providers and intake staff that you have celiac disease and require a gluten-free diet, and request a physician's order of a gluten-free diet to be put in your chart. And they are required to follow a physician's order for a gluten-free diet. Also ask to speak with a registered dietitian or a clinical nutrition manager or a food service director about gluten-free options, if you're having problems. And they would know more about the gluten-free diet than any other staff members. And a dietitian can work with you on selecting, the appropriate menu items, and they can also communicate your needs to the food service department. And, if there's no gluten-free menu available, select simple, naturally gluten-free foods such as fruits, veggies, plain hard-boiled eggs, yogurt, plain meat, chicken and fish, plain rice, and baked potato, etc. And also ask them, to prepare the food separately from other foods and on clean equipment or foil. Another good option is to have, a family member bring in food for you if that's allowed. And I want to mention also that a dietitian can provide patients with ready-to-drink nutritional supplements such as Boost or Ensure, most of which are gluten-free. Check for a gluten-free label. Be careful with meal supplements and shakes that are prepped in-house because things may be added to those that are not gluten-free. So, we can't plan everything in life, and hospital stays, they're sometimes unplanned, or, you may be too sick to communicate your needs. So make sure your primary care physician and all your healthcare providers know about your celiac diagnosis and need for a gluten-free diet. And, plan for a family member or significant other to inform, the hospital staff of gluten-free need in a situation like this. Appoint a healthcare proxy and set them up, with all the appropriate information. And you can also wear a medical bracelet with your celiac disease diagnosis and gluten-free diet restriction. And I also want to note here that parenteral or IV nutrition and IV medications are gluten-free. And most hospital tube feeding formulas are gluten-free as well, unless they add things to them. And how about assisted living facilities? So are assisted living facilities required to provide gluten-free meals? So that depends on if you have celiac disease and, a meal plan or food is included in the price of the assisted living facility, or, you're required to purchase a meal plan. So basically all residents or patients get meals, then they're required to accommodate a gluten-free diet per the ADA. And make sure to have, a letter from your doctor that states, your celiac disease diagnosis and gluten-free need. And like retirement communities where meal plans are optional, they are exempt, but many will still accommodate the gluten-free diet. So, you could still ask. And most medical facilities like hospitals and nursing homes and long-term care, they have to provide gluten-free diet because, they usually include meals for the patients, but they also have to follow the physician's order for a gluten-free diet. So you have both of those aspects. They have to follow the doctor's orders and the ADA. So it can be super daunting, making the decision to move to an assisted living facility, and then all of a sudden you're going to trust somebody else to provide you with gluten-free food. And we all know how tricky it can be. And it's really important that you find a place, that understand the gluten-free diet, and, they're willing to train their staff on the diet and appropriate preparation procedures, or they already have trained staff. So I would recommend researching facilities very carefully and interview staff before deciding on a place, and also ask around, ask friends and family for recommendations, and also check reviews online, and also ask in the gluten-free community as well for recommendations. And here are some helpful tips. Ask to meet with a food service director and registered dietitian on staff, to discuss meal accommodations. Those are really the key people to talk to about this. They have the most insight to how the kitchen and food service department work. If you're just speaking to a general director or another representative, they might not be as helpful because they don't have, adequate knowledge of what goes on in the kitchen and issues about specific meals. And often they're just told to, get people to be happy, with their decision to move in there. So, really definitely ask to speak to the food service director and registered dietitian. So here are some questions to ask. Do they have experience with serving gluten-free food? Are all staff members trained on preparing gluten-free foods? Do they have a separate gluten-free menu? And how many choices are on that menu each day? I asked to see that. And usually they have like a rotating menu. So I asked to see, for a few months. And will you have to pre-order gluten-free meals? Because sometimes you have to order, quite a bit ahead. And, how do they vet ingredients for gluten-free status? So label reading can be very complex. Do they have training on what to look for on the label? Are gluten-free foods prepared separately on a dedicated station away from other foods? Do they have dedicated equipment, like, the toaster should be dedicated? And how are gluten-free foods stored, prepared, held, and served? I would also recommend, visiting the dining hall and kitchen to see how everything works in person. And I would talk to the chef and the kitchen manager directly as well. And also, if possible, ask to speak to someone who eats gluten-free at the facility. And, you can hear directly from them how it's working. And that's really, you couldn't really have a better reference than that. Also find out if a kitchen or kitchenette is available in the room and what are your options for cooking and storing your own food. And another thing you really want to check is access to stores that have gluten-free foods nearby. And here are some helpful links. So if you're having problems, getting gluten-free meals, at the hospital or at an assisted living facility, where food is included, or, you're required to purchase a meal plan. And, you try to communicate this with them and, it's not going anywhere, then you should contact your state's attorney general's office for legal advice. And I have the link right here. You can also file a complaint at ada.gov, and you can also look at more information on there about ADA. And also this final link here, we have a free food service training available, which can be very useful to share with nutrition and food service staff if they're willing to be trained. And you can also find great resources at National Celiac Association. We have support groups throughout the nation, and also resources for seniors through our Supporting Celiac Seniors program. We also have a gluten-free food assistance program through Feeding Gluten-Free. So check us out at nationalceliac.org. So in conclusion, being a senior might present with more health and nutrition challenges in addition to celiac disease. And see your doctor and dietitian regularly for follow-ups, and eat a varied diet focused on gluten-free whole foods. And celiac disease is recognized as a disability under the ADA, and this gives you the right to accommodations for the gluten-free diet in certain circumstances. Thank you. I look forward to your questions.
Katarina, that was a wonderful talk. Thank you so much. And now we'll begin our Q&A session. I'm going to just mention again that this webcast is being taped. There was a lot of wonderful information on the slides from Dr. Murray and from Katarina. And if you want to review some of that, you can see the taped session on nationalceliac.org or on the Harvard Medical School Celiac Research Program website. So you can go back and re-examine some of the slides that you weren't able to glean all the information from in real time. There were a lot of questions regarding, let me read one. I'm concerned about the near future of needing to move to a group living situation where food is provided for me. What is the best approach for ensuring my safety? And I think Katarina covered that beautifully in the last third of her talk. And there's wonderful slides there that you can use to guide you. Another question: how do you find a qualified provider who even knows about celiac care? I can find none. Either of you like to address that, Joe?
So, Dr. Murray, do you want to address that, or?
Well, I can certainly have a go at it. It's difficult. Contact your Celiac Association. If you're moving to a new location, for example, that can sometimes be helpful. There are, seeking out referrals from people with celiac disease sometimes can be helpful. I wouldn't restrict yourself to gastroenterologists, because sometimes you may find a family practice physician or an internist or a nurse practitioner or even a physician who has experience with celiac disease. If you need expert care, though, because of ongoing symptoms or new symptoms that you feel might be related to celiac disease, then unfortunately you probably have to consider directly, going to a place with expertise in celiac disease, which will often be one of the celiac centers, for care. Beyond that, if you get a physician or a care practitioner who listens to you, who is attentive, who's available, you've got half the battle won at that point. Anyway, those are my comments. Katarina?
Yes. So we do have a search feature on our website, nationalceliac.org, where you can look for like the nearest Celiac Center. Also, celiac.org. They do have a really good search feature where you can put in your zip code and search for specialists near you as well.
Thank you, Katarina. Somebody asks if anyone has a sense of what % of senior living homes actually provide celiac safe dining. Does anyone have a feel?
So yeah, I don't have an actual percentage or anything, but a way they could, if they want to look for a place that are already, have been trained and certified, there are a couple of programs that do train food service establishments, including, assisted living and hospitals. And that is GIG at gluten.org. You can check that out. They do list which ones they have trained, and also the Gluten-Free Food Program at glutenfreefoodprogram.com.
We have a little experience. My colleagues here in our nutrition department have surveyed assisted living facilities and dietitians who provide supervision for those. And the great majority have very little or no experience of providing gluten-free, and there appears to be, while I think the key seems to be to make sure the dietitian is actively involved in the provision or the oversight of the food service. Obviously, I think it's now required in most states that nursing homes, for example, have to have a dietitian on staff or in a consulting role, but
Right.
How engaged are they in the actual day-to-day provision? So probably the single best predictor is, are they already doing it? Have they done it before? If they've never done it before, that may be a challenge for them to provide. That's at least been from our experience, much of it Midwestern.
Yeah, and just ask lots of questions, like I mentioned in my presentation, and really, push to speak to those key people, the dietitian and the food service director. They're the ones that are going to know about menus and how things work in the kitchen, and they're going to be able to kind of navigate that whole thing for you. And also another thing, if you do have that physician's order in there for gluten-free diet, they're required by law to do that. And also the ADA is a federal law, and that kind of overrides all the laws. So they really are required to provide the gluten-free meal. So if they can't, they have to get the training.
Good. Good. Thank you both. We've a question here about the high cost of gluten-free foods, and we are all aware that gluten-free foods are substantially more expensive than gluten-containing foods. And the question is, are there any supports available to help patients with celiac disease afford the gluten-free diet?
Right, so there are a couple of things. So we do have a food assistance program, Feeding Gluten-Free. So you can check that out at nationalceliac.org. And we usually connect you with, your local food banks or food pantries where you can get gluten-free foods. The other thing is, this is a little bit more complicated, but you can do you can write your gluten-free food off on your taxes, but it's not, sometimes it is kind of a can of worms to do that. because if you have several people eating in the family, you do have to subtract, the parts where other people in the family eats from that food. So you can only count the part where the person with celiac disease, that part that they eat, and count that towards your taxes. So that route is a little bit complicated.
Yeah, it to be something of an auditor to get all the numbers right.
Right, and also, check about coupons. In recent years, there, been a lot of coupons for gluten-free products, which is so exciting. They didn't used to be any coupons way back when. So, look out for coupons for products and coupon codes. Sign up for emails for the companies that make gluten-free products. And you can also email them and ask them, do they have any coupons going, or can you buy in bulk? That's the other thing. Go to, places like Costco, for instance, and buy, items more in bulk and things like that. And just eat, we also eat, just fresh gluten-free foods, gluten-free whole foods. You don't need to buy expensive specific gluten-free products. There are a lot of foods that are already gluten-free.
I think that's a good point, that regular, naturally gluten-free foods are the same for everyone in cost. It's only the specialized processed
Exactly, yeah.
that you have to pay extra for. So if you can shop them on the outside aisles of the supermarket, you probably won't be paying as much as you will if you buy, gluten-free pizza. In the freezer.
And another thing I want to note, let's say you have one person in the family with celiac disease and the rest of you don't have celiac disease. You don't have to buy things like the really expensive stuff like the gluten-free bread. We all know that costs, sometimes $7 or $8 per loaf. You can't have, just that person eating that bread. You can still make family meals gluten-free. Those are kind of easy to make, with whole foods, naturally gluten-free foods. But these kind of like specialized items like crackers and breads have, you can have like those just for the person with celiac disease.
Thank you. Next question. If you have no reaction to eating gluten, how careful do you need to be? I'm old, and does it really matter?
Oh, Ciarán, that's a very challenging question. It depends. I don't think that there is one. Obviously, the safest course for a patient with celiac disease is to remain strictly gluten-free. Even if eating gluten does not cause symptoms, it will cause injury in the intestine, and that injury could result in negative health consequences. But it has to be put in context. If I have a frail elderly person who is in their late 80s, for example, already having many health challenges, and they don't feel that a gluten-free diet makes them feel better, and they don't get sick when they eat gluten, I think it might be wrong to try and impose a gluten-free diet on them. We also have to be aware that our elderly patients, even if they are frail, don't necessarily have to be protected from themselves. Their autonomy and their dignity needs to be protected. And if they make a reasoned decision to eat gluten, even if it's in the context of a, say, assisted living facility or a nursing home, they should be allowed to make a reasoned decision themselves, properly informed. So there isn't hard and fast, and the older the patient and the more frail they are, and the less benefit they perceive, and the more imposition that a gluten-free diet is on them, then I think it's reasonable to consider other things other than being strictly gluten-free. At the same time, that should never be used as an excuse by care providers to not provide them with a gluten-free diet. That would be, I think, highly improper. So autonomy, I think, becomes more, and dignity becomes more and more important to our elders.
Joe, if you're looking after a patient in their 80s who decide not to follow a gluten-free diet despite having celiac disease, what sort of monitoring or testing would you do on those patients?
That's an excellent point, Ciarán. So I will follow their nutrient and vitamin levels. So they're typically their hemoglobin, a measure of iron stores, B12, folic acid, vitamin D, the things that I think will have a great impact upon them, are likely to have a greater impact upon them. And that should also enter into the discussion. So, for example, if they have bad osteoporosis and they're taking an osteoporosis drug, often an injectable, that may not work because of their untreated celiac disease, I would say I will have hopefully an open conversation with them about that we do have to be logical. We do need them to be sensible about it, but ultimately I have to honor their agency, let's say, in terms of making decisions.
Thank you. A question here that I think you will like. Can one indulge in a small bit of gluten if one uses Gliden-X?
I didn't hear the last piece.
Gliden-X. I presume it's a sort of over-the-counter.
I don't. Gliden-X or glutinases are over-the-counter things like these over-the-counter preparations that are supposed to reduce the toxicity of gluten, let's say. They've never been proven to be beneficial for patients with celiac disease. So I don't advocate their use. I don't recommend that anybody rely on them for benefit in terms of allowing them to be indulging in gluten. Each of those occasions has to be a consideration of risk for the individual. That said, my rule of thumb for adult patients is if they eat gluten more often than once a month, then I'm much more concerned about failure to heal or consequences than if it's less often than that. So I do think we have to be balanced, but ultimately, of course, I want to know how they're doing, how their symptom management, their nutritional circumstances, their antibodies, like their antibodies to be negative and stay negative, and also their, if I'm following them histologically, and they are eating gluten on an occasional or even frequent basis, I want to know whether their intestine is damaged or not, because their risk of complications is somewhat related to the degree of damage they have.
Question, does one ever get healed of celiac disease, or does it get worse as we age?
Oh, it's an excellent point. So within the immune system and autoimmunity in particular, there are two trends. There are some diseases that burn out. So there's some chronic inflammatory conditions that seem to become less active, though they may have left people with significant disability. On the other hand, there are some diseases that seem to become more aggressive autoimmune disease, and it varies from individual to individual. In general, I don't see patients becoming more sensitive as they get older. There is one significant thing I do tell patients at the time of diagnosis. I diagnose a patient with iron deficiency anemia, and they don't have any other symptoms. But then 2 or 3 years later, they're gluten-free and they get exposed to gluten and they get symptoms, quite significant symptoms. And they're upset at that. And that is a real happenstance in some individuals. Hopefully it's very short term. So I don't know. I think you have to individualize it. Also, some individuals, their gut becomes, I won't say less sensitive, but they complain less. And maybe that's because they've complained. They're tired of complaining to doctors because the answer they get is often the same. The only answer they have is, you're gluten-free, be gluten-free, be gluten-free. And as Ciarán, as you've been very much engaged in addressing some of these needs, the needs for patients to have treatments beyond a gluten-free diet, I think it's clear that at all ages, there is some perceived need that the gluten-free diet itself is not effective for all patients, and it is very burdensome at all ages.
There's a general question, which I'm not sure I completely appreciate, but the question is, do you have any suggestions on using Medicare insurance for routine celiac care?
Okay, so one of the big bugaboos with the management of celiac disease is getting any insurance to pay for the dietary consultation. It is unconscionable that in the 21st century, that for a disease such as celiac disease, for which the treatment is a diet that requires substantial engagement, education, burden, cost, that patients don't get coverage for the single most important person, that is the expert registered dietitian who can advise them. I mean, that's just unconscionable. There are some ways around it. One way is where the dietitian consultation occurs incidental to a medical visit. And that is, in some circumstances, can increase the payment. Now, whether the reimbursement is at the same level, I don't profess to understand much of that. But that has been a successful strategy in some circumstances where the dietitian is on staff and the dietitian's consultation is carried out incidental to the physician evaluation, which doesn't have to happen on the same day even. And so that's one circumstance. The other is that testing for celiac disease should be a diagnostic test for diagnostic care, not a screening test. And we often use that term screening maybe too broadly. And strictly screening is when you test for something where the person does not have any signs or symptoms or consequences of that disease. That's the only circumstance which is testing. So if I have an older individual who is the parent of a patient with celiac disease, I am sure they have a symptom. They must have some symptom that could be celiac disease that is then the reason for the test. And that increases the likelihood for the disease. So that would be my approach. And Katarina, maybe you have more insight into this issue.
Right. So currently, unfortunately, with Medicare, it doesn't cover for, visits for the gluten-free diet. And that is just really not acceptable. I know the AND, the Academy of Nutrition and Dietetics, they're trying to push to change that. And I think they have some petition out. So if you go on their website, eatright.org, you can, I think, sign that. So currently, it's under Medicare, nutrition counseling is only covered for diabetes or kidney disease. And it's very important for those two conditions, but celiac disease, is just as important, to have proper counseling for gluten-free diet. It's, it is the medicine to treat celiac disease. So it's just really vital that, that would be covered. And we're hoping that it will be covered in the future. I'm not quite sure where they're at with that bill. I think they have introduced a bill for that.
So I want to thank Katarina and Joe for their wonderful answers. You've worked overtime. We've gone a little over our time, but it was good. We got some excellent answers in. And I want to hand over to Lee Graham again.
Thank you, Dr. Kelly. Our May 19th webinar will be Elite and Everyday Athletes with Celiac Disease, Eating for Fitness at All Ages. Whether you're an elite athlete or just enjoy taking a walk, leading an active, healthy life is important for everyone, including those with celiac disease. The link is up and registration is open at nationalceliac.org. Continuing education credits are available for dietitians, nurses, physicians, and social workers. And until then, from all of us here, see you next time and stay well.